Welcome to all listeners to another FSC Radio podcast episode. My name is Santiago, and I'm joined today by Nina to talk about a topic which I'm sure has crossed our minds at some point. Whether it's from a friend who suffers from it or a family member, diabetes is no mystery to anyone anymore. Despite all the new medical technologies developed in medicine, there seems to be no cure for diabetes yet. But to learn more about this, we're here today joined by Sandra Smink. Welcome.
Thank you.
How are you doing today? How are you feeling?
I'm fine. I'm excited to be here.
Is it the first time that you're in one of these interviews?
Yes, I am. Yeah,
Okay.
It's the first time. So looking forward to it.
Great. So first question that how we usually start is learn a bit about you, to get the listener familiarized with you. So you work on diabetes, specifically type 2, but how did you
Type
arrive?
1.
Type 1, sorry, yeah, my bad, sorry. Type 1, I always miss with the type 1 and type 2. How did you get interested in this field?
Well, it's actually funny because when I was doing my bachelor's here in Groningen as well, I had to write a book chapter about diabetes. And then after finishing it, I was like, okay, this is very boring disease. not so interesting. So, but then I finished my master, and there was a vacancy for a PhD position, and it was about type 1 diabetes. And I just really the vacancy looked interesting, and also the methods that they used, and the group in where it was. So that's why I decided to do it, even though it was about diabetes. And then after 4 years doing a PhD, I felt it was not finished yet, so I kept on going. And now I'm here 14 years later, still in the diabetes field. So, yeah.
So it feels like a pretty linear trajectory, but just before the podcast, we were talking that you spent some time overseas. How was your trajectory before becoming a professor?
Yeah, so like I said, I studied here, my bachelor and my master biomedical sciences here in Groningen. And I also did an internship during my master in Melbourne in Australia, and then applied for a PhD position at the UMCG at the Pathology and Medical Biology Department with Professor De Vos, which was about developing a transplantation site for islets for type 1 diabetes treatment, in which we talk about more detail later, I think. So after finishing that, I got the opportunity to do a postdoc, first in the same group, and then later on also I did a postdoc at the University of California in Irvine, so the USA, with Professor Lakey, still similar topic. Working on developing my own research line in how to make such a transplantation site for insulin-producing cells for type 1 diabetes. And then I came back, and since 2023, so now for almost 3 years, I'm assistant professor, still at the Pathology and Medical Biology Department in the UMCG. So, yeah.
So I'm a bit curious because I am aware that the UNCG is quite, it used to be more Dutch heavy, now it's turning more into English. Was it when you were studying still in Dutch? And if so, was it difficult to then transition towards English-based study?
Well, in my bachelor's, the lectures were still in Dutch, but the handouts and the books were already in English. And if we had to write something, then it was also English. And then master was completely in English. Okay. Yeah, and at the UMCG, at least in the research group I was in, or in my own research group, there's a lot of international people. So then it feels weird and not polite to do it in Dutch, right? So there's a lot of communication in English. So I would say most is in English.
Okay, so what is a day in your life like as a researcher?
Well, I start quite early in the morning because I need to travel for an hour. But then when I come here, I usually start checking my email, my to-do list and my agenda for the day. And then one of the first things I like to do is to go to the animal facility, because I do some animal research. So if I have animals, I go there to check them, to be sure that they are doing fine. And then the rest of the day is always very different. Each day is different. Sometimes there's days with a lot of meetings, research meetings, but also policy meetings, all kinds of things. Meetings with PhD students, but there's also periods where I teach more, so then I sometimes need to teach or coordinate a course. So it's very difficult to say how a particular day looks like, but in general it's very variable, and that's what I also very much like about the work, because it's never a dull moment.
You mentioned you work with animals. I assume mice or rats. Like, is there an ideal animal that you would use for experiments with diabetes, or?
I use both mice and rats, but I also in my postdoc in Irvine I did some pigs.
Wow.
That's very difficult to do here in the Netherlands, but. And mice and rats give a very good insight in the treatment that you thought of if it's working. But then the reason why we also tried pigs there is because I'm looking at a treatment that involves the skin, and the pig skin is very similar to that of humans. So that's why that is a nice step in between mice and rats. And the clinic, so human, experiments.
I don't think in my time as a biology student we talked about experimenting on pigs, so that's really interesting to hear, actually.
So now, getting a bit closer to the topic of today's, what is diabetes? And then I was also curious to think, when was this discovered? When was the first signs of like, oh, diabetes is actually a thing?
Yeah, so diabetes is a lack or a relative deficiency of insulin. So the human body does not produce insulin at all, or too little, or it does not respond well enough to insulin to store to control your glucose metabolism. And this was discovered, at least diabetes was named a few hundred years before Christ already by a Greek doctor, I think, or I'm not sure if they were doctors already by then, but because and it was called diabetes mellitus because diabetes indicates that it was about fluid regulation, because they saw that these people went to the bathroom more often, so they lose a lot of fluids. And then this fluids, this urine was more sweet, so that's why they called it diabetes mellitus. Yeah, so that's a bit of the background. And then, so I'm focused on type 1 diabetes, which is an autoimmune disease where the human body destroys actually the insulin-producing cells, which are located in the pancreas, and these islets of Langerhans. And then in this way, the body is not able to produce insulin anymore to control the blood glucose levels. And the other type, often known as type 2 diabetes, where these patients do produce insulin, but they're often less sensitive for the insulin. So their receptors don't respond as well as in a healthy person.
And we always make the distinction between type 1 and type 2, but are there other types that are maybe very rare?
Well, there are a lot of subtypes for type 1 and type 2 that are less known. But the third type is GDM, so gestational diabetes mellitus. So this occurs when you're pregnant. And some people then develop diabetes during pregnancy, but as soon as they deliver the baby, the diabetes is also gone, kind of. So although they are at risk for developing type 2 diabetes later after pregnancy, but this is a fascinating type of diabetes because it's kind of temporary.
Yeah. Is there there's research on maybe like how it happens, or is there any way you could explain that it suddenly happens and then it goes away? Or
so when you're pregnant, I believe your body becomes a little bit less, a little bit insulin resistant, like type 2 diabetes, and this is needed for the baby because also glucose needs to go to the baby. So you need a little bit more glucose in your system, I guess, in your blood to also provide your baby with enough energy. And so apparently this mechanism can also go too far, and then you develop diabetes during pregnancy.
Yeah, and I guess there's a threshold then.
Yeah,
for that. Yeah. Oh wow, I've never heard of this. It's so
fascinating. I was wondering, you mentioned with type 1 diabetes that it's an autoimmune disease. What are autoimmune disease and how do they occur?
Yeah, so an autoimmune disease is when your own body attacks certain cells, in this case the insulin-producing cells, and destroys them because the body thinks they are foreign or should not be there. So for type 1 diabetes, it's not very clear why the body does this exactly, but the immune system attacks those cells and destroys them, and in this way creates a disease while it should be accepting these cells because it's just your own cells. Yeah.
So the mechanisms of this carrying out are not very clear yet.
No, they're different. There seem to be different reasons, and a lot of research is done into what's the chicken and what's the egg, right? But for example, it can be genetic reasons, but it could also be virus infection. So there's some publications about with coronavirus. The coronavirus triggers the immune system, and by this trigger activates the immune system as such that it also starts recognizing antigens or insulin cells in this case as foreign. So it could also be influenced by that. So there are some publications that since the coronavirus there's more type 1 diabetes, for example.
What are the demographics like? What is the prevalence like for maybe men or women, the ages that you would get type 1 diabetes?
Well, the type 1 diabetes is often diagnosed at a young age because, in the first few years, the body is still able, I think, there are still some insulin-producing cells that can control your blood glucose level. So it's often diagnosed, I think, maybe at earliest 6 or 7 years old, something like that. Kids, so young kids, but also nowadays more and more people get diagnosed on later age. And that could be influenced by these viruses, right? For example, that you are exposed on a later age, and this is why you develop type 1 diabetes. So that's there's not really a certain age or a group. I think it's a very heterogeneous group of people from very young to older. But it used to be the difference between type 1 and type 2 diabetes was always set as age, because people said, okay, type 2 diabetes, this is developed because of lifestyle, and so that's often the older age. So people on older age, that they get type 2 diabetes, and then the younger people that were type 1. But it's not that gray, black and white. There's a lot of gray in between, I think.
So it feels like type 1 diabetes is heavily genetically, but then because you mentioned that later on in life, you also obtain them, there is a big factor of environmental, but you're mentioning viruses, but viruses are not new to the human, right? They've been around for thousands of years, millions, more than us. So what are other factors that people are maybe thinking that could cause this?
I think I don't know if you're familiar with the hygiene hypothesis, because it also occurs more often in the Western countries, and they say, okay, we are too clean, we are not enough exposed to microbes and viruses and all kinds of things to really develop our immune system, and that's why it sometimes goes wrong. So that's also one of the hypotheses behind type 1 diabetes.
This reminds me of my microbiology professor suggesting us to let our kids eat dirt when they're very young. So then they get exposed to more immune, so then later on they don't have autoimmune disease.
Yes.
Why is it so difficult to cure them?
Well, now what they do is they treat type 1 diabetic patients with insulin because they don't produce it by themselves. So to control your blood glucose, they need to inject insulin, and this ensures then that the glucose can be taken from the blood into the organs where it can be used as energy source, or it can be stored for later on energy. In a normal body, healthy body, this happens really on a minute-to-minute basis. So it's very tightly regulated. And although the insulin treatment helps these patients very much because the blood glucose levels don't get so high anymore, and also not for such a prolonged period, but it's very difficult to really get it so tightly regulated as the body normally does. And therefore, often later in life, they develop other complications, and often with organs like the kidney or their eyes, cardiovascular diseases, because these fluctuations in the glucose levels affect these organs on the long term.
What would we need as the scientists to know to be able to accurately develop not patches for this autoimmune disease, but actually solve them in the long term? What is it missing right now?
So do you mean like missing to prevent or to treat?
To treat.
Yeah. So I and other researchers are looking into if we can transplant insulin-producing cells to these patients, so actually give them new insulin-producing cells. But then we need to know what they need to survive on a long time, right? So there's several things we need for that, because one of the things is the autoimmune response. How do we prevent that these cells are attacked again? But also, if you are transplanting insulin-producing cells from a donor, for example, you also have the rejection autoimmunity. So you need also to prevent that. But besides that, there's already some is used in the clinic where they transplant islets, so the insulin-producing cells from the pancreas, into patients actually, and they transplant into the portal vein of the liver. So, and then they see that these patients very well regulate their own blood glucose levels without extra insulin. But after 5 years, they're back to where they started. So they need to inject insulin again to control their blood glucose levels. So it seems that the cells die over time. So, and there is not another transplantation site in the human body that helps these cells better. That was research. So my research focuses also a lot on can we create a transplantation site where they can survive for a very long time and where they can function for a very long time.
You mentioned that when people inject insulin, when they have low blood glucose, that it then that there's a fluctuation of symptoms as well. Could you say that? And if so, what are the symptoms then of type 1 diabetes?
So they inject insulin when their blood glucose is high, because to lower the blood glucose, the insulin is needed to take up the glucose from the blood into the organs.
Yeah.
So there's I think two types of things, or two. You can either have a high blood glucose level, and that gives symptoms, but you can also have a very low blood glucose levels, and that also gives other symptoms, right? I'm not a physician, so but I know, for example, with the very low blood glucose levels, your brain can stop working, right? Because you doesn't have enough energy, so you're faint, or even worse, you get into a coma or something if it's for a very long time. But maybe the first symptoms are shaking, right? If we not feel well, if you did not eat well enough, you also start shaking. Your body needs some sugar to function. But if it's very high, then there's other problems that can occur. So there's a lot of different symptoms, but one of the symptoms I said where often people are how people often are diagnosed is because they have an increased thirst. They drink more and they go to the bathroom more often because they need to pee more. So this is, so there's all kinds of different symptoms associated with this disease.
Yeah. So then I assume that there are some which are more prevalent when you inject insulin than when you do not have enough in your body.
Yeah.
So does that then influence, I can imagine that influences someone's lifestyle who's living with type 1.
Yeah.
Like it's exhausting probably.
Yeah, so you cannot say today I'm not doing anything. It's there 24 hours a day. It's very interesting to see how the body normally regulates your glucose levels, because if you don't have type 1, you don't think about it. But even if I think about eating in a few minutes, for example, my brain is already sending a signal to my pancreas saying, okay, pay attention. You need to release insulin very fast in a few minutes, probably. So it's very complex, regulated system, tightly regulated. So you can imagine if you then have type 1 diabetes, you need to think about every time you're going to eat or drink something that you need to inject insulin, or you need to predict how much you're going to eat and how much this will influence your blood glucose level. So it's quite complex, but then also it's not only about eating and drinking, but also if you go sporting later on, this influences also your energy level, and you might reduces your blood glucose level faster than you anticipated. So it's complex, and I think it's also very has a large impact on the whole family, especially when it's younger kids, because then the parents need to regulate, but then kids just want to eat candy, or they sometimes eat candy without telling their parents, right? They want to do it secretly because that's very difficult. But also sometimes these patients get very low glucose levels during the night, and then they themselves, or if they're very young, the parents need to also be at night very active on controlling the blood glucose levels. And I think nowadays there's more, you have these insulin pumps that control the blood glucose levels by themselves, kind of. And this is very helpful, I think, for these patients. But still, you need to make sure that that's working and that you check up. So, yeah.
What happens when nothing is taken? Let's say you have suddenly a drop in glucose. Is it your energy level goes down, or is it also your mood changes? What happens if one person has type 1 diabetes but doesn't know it and doesn't treat it?
Yeah, so then I think at some point you don't have enough glucose going to your brain, and then you faint or end up in a coma. Yeah, these hypos and hypers is what they call them, and so very low or very high. Those are the very dangerous moments for these patients, and where they sometimes end up in hospital, because even though they're trying to regulate it, it's sometimes very difficult to prevent them.
And are these things common? Like, is it rare for someone to faint if he has type 1 diabetes?
I cannot really give a number or something, but I know that it's very difficult to prevent them at all.
If it don't happens today, it can happen at any point, and that is,
You mentioned insulin pumps. What are the types of treatment options other than insulin pumps, or maybe you can tell us a little bit about how they work? Or
so mainly these patients, they when they are diagnosed, they start off with insulin injections, but at some point nowadays these insulin pumps are also very well integrated, I think, in the treatment options. But they at the beginning they need to figure out how much everybody needs to get used to it, and they need to get a rhythm in how to inject and how to check their blood glucose levels. And I think as soon as they're a little bit more used to that, then they can get such a pump. And this pump then measures itself what the blood glucose level is, and then injects the amount of glucose, the amount of insulin, to balance the glucose levels. But there are still some patients that, even though with this pump they don't get their glucose levels under control, and those are the severe cases. I think that they really struggle, and at this moment it's sometimes these patients then need, for example, a new kidney later in life because they struggle to get their glucose levels under control and their kidney failed. So they get a new kidney, and then sometimes now they also get then some new insulin producing cells. So they get islet transplanted as well. But this is only really done by with the patients that really struggle to get their glucose levels under control, and that they also already need a new kidney, for example. So they already need to take immunosuppressive drugs to prevent rejection of their kidney, so they can also get some islets, because the treatment is not optimal for the whole patient group.
Mm.
So I feel like these islets is just a bit of a once the pump has been tried and we need a new kidney, now we try the islet insulin producing cells. How do these, I know you've mentioned it before that you try to have some insulin producing cells outside of the like in a specific place in the pancreas, that then is it's able to survive but not to get killed by the autoimmune by the immune system. How do you prevent the immune attack? Is it in a specific matrix that the immune system cannot go in, or is it immune suppressors on the around these islands?
Yeah. So at the moment, if it's done in the clinic, then they get the immunosuppressive drugs, so to prevent rejection, but also this also prevents the autoimmune response. And then, but we probably all know that these autoimmune drugs also have risks, right? You have, so it damages also the body. So that's why research looks into how can we transplant without immunosuppression. And there's several ways people investigate how to do this. An example is that you can encapsulate these cells in a little layer of alginate, and this alginate layer blocks access from large immune cells to the islet, but still allows glucose and insulin to diffuse in and out, so the cells can still function and can connect to the body, but it prevents. It has a barrier to the immune system.
It's something like a cage that it has around it.
Yeah, a little layer. It's encapsulated, so really protected, a protective layer, as you can say.
And is this somewhat working?
Yes, definitely in animal models it's working, but it's not used in the clinic yet. No, but it's just one example. There are other examples where they try to manipulate the immune system or genetically engineer solutions. There's different. You could also think about co-transplanting mesenchymal stem cells, for example. They have some immunoprotective function. And in this way make a local protection. So there's different ways, but none of them are ready for the clinic yet.
I'm wondering also how researchers are approaching these problems. So you mentioned of these different islets and islands, but this is a bit of just put in a bit of a patch. That, as we've seen, as you've mentioned, it only really lasts for 5 years. Are we looking at making these islands last forever, or are we looking at some reversing of the type 1 diabetes? Or are we also looking at preventing it at all, if that is even possible? What are the different options researchers shuffling around?
Yeah, so that there are definitely researchers also, I would say they're not, before we can prevent, we need to know what the causes are and how it works. So there's researchers focusing on that. But yeah, the research field I'm more in is more about curing. And then ideally, we want to transplant and cure the patient for the rest of his or her life, right? Because also we know that there is a donor shortage, just so you don't want to use too much donors and multiple donors for one patient, because that's not feasible. But at the moment, it's the transplant is you already need 3 to 4 donors to transplant enough islets to one patient. And if you then think about, after 5 years it's not working anymore, and think about that this kid develops it at, say, 7 years old, it's not feasible to transplant this kid every 5 years because there's simply not enough donors. And so this this islet transplantation is at the moment not available for all type 1 diabetic patients. So research focuses on how can we improve that, and could we? So my research focusing a lot on how can we improve the transplantation side so that they have enough oxygen, nutrients, but also can connect with the nerves, have interaction with the brain, so that there's all kind of modulation there. Kind of creating the optimal transplantation site. That's the goal. But there's also researchers looking into how can we make insulin-producing cells from stem cells, so that we don't need a deceased donor anymore to isolate islets and then transplant. So there's different options there.
You mentioned donors and that it takes 3 to 4.
Yeah.
That's a lot. I did not know that. Do you maybe know how they are selected by chance? Maybe characteristics they should have, or
I don't know exactly. So it needs to be deceased donors, because they take out the pancreas of this donor. And this cannot be done while you're still alive, right? Because that's also the donor's only source of insulin-producing cells. And they isolate in the lab, take out the islets, because the pancreas is existing of all kinds of other cells that we don't need for transplantation. They isolate these islets, and then there need to be 4 deceased donors that kind of match with each other and match with the patient. So you can imagine it's quite a difficult process. And then the isolation quality also needs to be good enough, because sometimes that does not work out. And still also researchers are working on that. How can we further improve this isolation process? Because there's 1 to 2 million of these islets in your pancreas, but we don't isolate that much islets when we take them out. So there's also possibility there to improve, to get more out of one donor.
You mentioned that you were in your specific treatment, you're looking also at making the connection between the islets and the brain.
Yeah.
How do you achieve this? It feels like somewhat you're making a bit of an organoid within the pancreas.
Yeah, so maybe I can explain a little bit more about my research. So I developed during my PhD, a transplantation device made of a polymer, and we want to implant this under the skin, because that's a easy accessible site. You don't need a major surgery for that, and we leave it there in our rodent studies, for example, in our mice and rat studies, we leave it there for 4 weeks, so there's no islets in there yet, and then during these 4 weeks blood vessels grow in, for example, but also we want the nerves to grow in there, because the blood vessels very important for the exchange of oxygen and nutrients, but also for the islets to be able to measure the glucose and release insulin. But then the nerves are important. Like I said, if you're thinking about food, that there's already a signal going from your brain to this new site for islets, giving a signal, okay, you need to produce insulin. So in this way, I think it's also important to connect to the to the nervous system, but also there's a lot of factors. I think important extracellular matrix, for example, plays a role between communication between blood vessels and these islet cells, but also maybe lymphatic vessels, important to get rid of certain fluids or So there's. So I'm trying to use tissue engineering to create this optimal transplantation site within this transplantation device that we then plant under the skin.
I'm a bit curious. I have a roommate studying biology, and he's very passionate about the microbiome.
Oh, yeah.
So I'm curious because there's been a big boom recently in biology talking about microbiome, all the things that it does. Is it something you're looking at, or is the pancreas a place that is isolated and there is no microbes and it's not something so relevant for this type of approaches?
No, I think there are definitely some publications about microbiome and type 1 diabetes, but there I think it's still not clear what's the chicken and the egg. If it's first a microbiome change that results in the development of type 1 diabetes, or that the development of type 1 diabetes results in microbiome changes. But there's also some fecal transplant studies where the transplant stool of a healthy person into a type 1 diabetic person, and in this way modulate their microbiome, and they benefit from that for their glucose regulation. But
I mean, if people with type 1 diabetes would experience dietary changes, is that common? Would it then... then I feel like it would influence the composition of the microbiome.
Yeah, definitely, and especially type 2 diabetes.
Mm-hmm.
These patients often their insulin insensitivity is often very much improved when they change their lifestyle. If they eat healthy and sport, all the things we know we should, right? If they make big changes, then their disease already improves. Might also have to do with the microbiome. Yeah.
I wrote my thesis on the microbiome, so I also geek out on it a little bit.
Yeah. I was wondering, you're talking, these are all, of course, great ideas, but then at some point they need to be implemented, they need to be tested. I know a bit already about this because, I had a course with you about tissue engineering. But for people that are not so familiar with this, how long does it take between you have an idea, you say, I have some preliminary results in the lab with no testing. This looks promising. How long does it take to actually get into clinical practice?
Yeah, this is a very difficult question always, and I always get these from patients as well. And I would like to say, within so many years it's there, but it's very unpredictable, and I also don't want to give patients false hope. But I think at the moment there's great steps done with for example with the stem cell producing the insulin producing stem cells, where they actually also used in the clinic to transplant. So this is a very important step to make it more available for more patients, and I think making it a transplantation available for all type 1 diabetic patients, that will take very long, I think. But more short term, there will be improvements for the ones that already get an islet transplant, for example, or get these stem cell insulin-producing cells. In 5 to 10 years, I think it would be nice to see more steps into the clinic. But then, I'm already working for 14 years on this transplantation side, and I'm not in the clinic yet. So it's very difficult to predict. Although we definitely do our best to get there.
I'm curious also. Most of us, a lot of us, probably know that with type 2 diabetes, there is this famous drug that has been developed in the past years, Ozempic, that was developed by a pharma company. I'm curious how much of type 1 diabetes is researched by research institutions, and if there is also pharma companies working on type 1 diabetes.
Yeah, so there are definitely more on type 2 because I think, that's also the balance between, from the patients with diabetes, about 90% has type 2 and just 10% has type 1. So it's a smaller patient group. But there are definitely companies like Novo Nordisk that work on type 1 diabetic research, but also institutes, of course. There definitely are people working on it, and especially the generation of these stem cell insulin-producing cells. There's several companies that try to further to push that towards clinic. So those are at the moment very important, I think, for type 1 diabetic research.
You mentioned specifically this stem cells. This feels like somewhat the way forward that the world, the researchers in the field are taking. You mentioned that in 15 years we may see some advancements in the current methods with these stem cells, but is it foreseeable that maybe in 50 years, in 60 years, this type 1 diabetes can actually be cured? Will it ever be cured?
That's, I think, the goal of all type 1 diabetic researchers, so I hope so, yeah. But don't pin me down on that, but we work very hard to get there, yeah.
But are there signs that are like maybe this is just an incurable disease that is very complex and there are no really methodologies in place?
Yeah, so I think it makes it a complex disease because it's very heterogeneous group of different people developing at different ages, different reasons. So it could, it's a big challenge to solve it for all these patients, I would say. But I think definitely there will be improvement for some of these groups.
And I assume also one of the big improvements that we will probably see is daily life. Daily usage. How can we expect for people who have type 1 diabetes to improve their lifestyle with the current methods?
Well, I think the current insulin pumps that they are improving still, and they are getting much and much better. So that's very important for these patients. And you could also think about now maybe this pump is only injecting insulin, but because we are always focused on insulin, but might be also important in these islets. They're not only insulin-producing cells, but also cell types that produce other hormones like glucagon, for example. I can imagine that, and I know that people are working on that to extend this pump system with not only insulin but also glucagon, for example. So then it makes even more complex regulation possible.
I have a question maybe which is like maybe outside of your scope, I'm not sure. But you mentioned that so these insulin pumps are obviously like being advanced. Do you feel like AI could play a role in this, of maybe like detecting in advance when someone's glucose levels are fluctuating? Or
yeah, definitely. I think the AI can help improving the systems as well, and can help people anticipate better in their daily life. So yes, and I think this is great, but still, you might wonder why I'm then looking into transplanting cells, right? That sounds much more difficult than optimizing a pump or improving these systems. I think in the end, if the human body can regulate it by itself again, that is the ultimate goal. I think in the end, the best, but we are not there yet.
All right.
As we're drawing a bit close to the end, I want to ask you a bit of a message for the people. Maybe you're not so knowledgeable in this area, but we've talked that type 1 diabetes, well, it can be greatly genetic. It can also be influenced. What are some things that you would recommend to people to avoid type 1 diabetes?
Well, I think it's very difficult to avoid it, right? People don't know on forehand if they are developing it. So I think it's up to the researchers to investigate how can we maybe prevent it or detect it earlier on to maybe stop this autoimmune reaction. But I do. Again, I'm not a physician, but I think it's very important for the patients, if they have it, take it seriously and try to regulate it as best as possible, because that in the long term gives you the best outcome, I think.
And maybe as a final question, what keeps you motivated despite the difficulty of autoimmune diseases like type 1 diabetes?
Well, it's definitely the patients itself. On a regular basis, I present my research, for example, to patient groups, or I talk with patients. Sometimes I have students in the lab that they have a relative or themselves have type 1 diabetes, and this really helps to put it in perspective and to again remind you of why we are doing this and why we want to need to develop a cure. This keeps me very much motivated and triggers me every time when there is something not working to find a way around it and keep on going. Yeah.
Well, hopefully you can reach more people with the podcast then as well.
Yeah, that would be nice.
Okay, then with that, we'd like to thank you all listeners, especially to you, Sandra. Thank you very much for being here. And we'll catch you on the next one.
Okay, thank you.
Thank you. Bye.
See you.